Does polypharmacy, taking multiple medicines, become a problem for patients with heart failure?
Absolutely. So in fact, one of my co-authors of this study, Janine Beezer, has done an excellent systematic review on polypharmacy and heart failure. So go and read that, first of all, for people that want to learn more. But yes, your average patient, again, develops heart failure because of all these other conditions. So long before they even end up with heart failure, they're already on polypharmacy, and heart failure just contributes to it. So we have to kind of attempt at least to rationalize that a little bit. There might be things that we can scale back as we put you onto the heart failure type medicines that benefit you, because maybe you're on different blood pressure tablets that you don't need anymore. Perhaps you're on other medicines that are actually have contributed to the development of your heart failure. So we know that certain medicines can be implicated in causing heart failure in the first place. Things like certain diabetic medicines or certain painkillers. So we can sometimes must stop medicines because they're actually worsening the scenario. We also know that by the time you develop heart failure, that some of the medicines that we might have had you on in the past maybe are unlikely to benefit you now. So we can rationalize things and scale back on some treatments a little bit. So yes, we shouldn't just be looking at our drugs. We should be looking at all the other drugs that you're trying to do, and to think about whether we can rationalize them a little bit as well. And by doing that, actually, you generally make the patient relationship a little bit better, because patients don't want to take as few drugs as possible. And you can actually make sometimes medication adherence better, because the more and more medicines that you take, generally adherence suffers a little bit. So yes, national, international guidelines all ask us that when heart failure is diagnosed, that we don't just look at those 4 drugs, that we go and we look at all the other stuff and try and rationalize that a little bit as well.
I see. So what's the best way to manage all of this? I mean, who should be overseeing prescribing and management for these patients?
So the short answer is it should be a team approach. The slightly longer answer is, what do patients want? Patients typically want to be treated as close to home as possible by the person that they get the most relationship with and has the skills and the knowledge to treat them appropriately. So in lots and lots of cases, that can be somebody in primary care. So the prescribing for sure should sit in primary care, and a lot actually of the management decisions can sit in primary care as well. There's times in a heart failure patient's journey that they probably would benefit from seeing a specialist. So that might be when you're newly diagnosed. So we really understand what's causing the syndrome of heart failure, what type of heart failure you have, and maybe to set the first kind of idea of what we think the management plan in an ideal world should be for that patient. So that fundamental first few weeks and months, probably a specialist involvement to help some of that formation. Some of the causes of heart failure are actually reversible. So again, we can, if we don't get that phase right, we sometimes mismanage people. So specialists are needed. But then as we go through, we now know the plan and we've got the plan. Some of the delivery of the upscaling of that plan, of the monitoring of it, if we're being honest, should probably live in primary care. Now, I'll give you one last reason also why that's true. So the development of heart failure in most people happens over a long time through the consequence of other conditions. So the first person always that somebody goes to and thinks, I'm breathless, I'm tired, I'm fluid overloaded, is generally always a general clinician, a general practitioner, a general nurse, a general pharmacist, and an acute general physician in the front door of accident emergency. So we cannot beat heart failure through specialists alone. We need our generalist colleagues. We need really upskilled generalist colleagues that know what heart failure is, the basics of how to diagnose it, and really can forward and follow treatment plans.
As an experienced cardiology pharmacist, what would you say to a young pharmacist who was wondering whether cardiology pharmacy is a career path worth following?
What do most people in healthcare, let's take healthcare, what do most people in healthcare want from their job? They want paid well and stuff. Taking that aside, they want to be effective. They're generally altruistic and they want to help people. They want to be part of a team, and in that team, they want to have a purpose. They want to have some belonging, some camaraderie, and they want to offer something meaningful to patients. I would suggest to you that cardiology is one of the prime examples where a pharmacist can do those things. So it's very clear what we're trying to do and what the goal of our teams are, to prevent heart disease from reoccurring in the future again, is to treat patients as individuals. Because there's a common goal, it's a very collegiate, team-based approach where everybody knows more or less that they're pulling in the same direction. So the purpose, the belonging, the kind of meaningful work that you get, the ability to use your skill set as a pharmacist with these complicated factors to look at the patient in front of you to try and get them on to the most appropriate and the best treatment. I believe that you can meet all of these conditions working in heart failure or cardiology as a pharmacist. And that's not always true in all walks of life. And I actually think, therefore, that the professional satisfaction that you would get is as good as you'll find anywhere in any condition. And therefore, that the good that you'll do, you'll go home thinking that you helped people. And that's probably what drew most people to pharmacy in the first place, that I want to be altruistic and help.
Very inspiring. So a quick follow-up. Does this area offer significant scope for pharmacists as prescribers?
So what pharmacists now, from 2026 onwards, all pharmacists that leave university are independent prescribers from the first day that they register. So this is an area where, with the right support, the right governance, the right team around you, people can say, I've got patients you can help if you want to prescribe. Come and work with me, because I've got patients that as long as they want the treatment, benefit from these 4 drugs that we want to give them, and we can't get them onto them quick enough. So it's an area where the MDT and the community, like me and the doctors and the nurses, everybody's saying, come and work with us. If you want to prescribe, we'll help you, and you help us, and we all help the patient. And there's very few places that are like that. So it's a place that you can really find a home, like as somebody that's trying to move into slightly these more, modern, advanced type roles, which is not just about giving medicines out, but it's actually about managing patients. So I think heart failure is one of the real success stories of this kind of working, and nurses as well. Nurses are fantastic at this, so it's not just pharmacists.
Nice to hear. Paul Forsyth, thank you very much for sharing your insights and experience with us today. That really has provided a great deal of food for thought. For more information about Paul Forsyth's work, please visit our website using the links in the description. And be sure to sign up for more news, videos and journals. For updates straight to your inbox, please follow the links below. And thanks for watching.